So when I began making house calls in 1992, I did not do any of the right things. I'm a physician. I'm not an entrepreneur, okay? I did not do market research. I did not write a business plan. If I had, market research would have told me what I quickly found out anyway, that the need was huge and growing. The business plan would have told me, don't bother. There is no money in this. You're not going to be able to make a living at it. But because the need was so compelling, and I had already started doing it, I couldn't stop. I kept going. And I wouldn't have heeded that warning. And I'm so glad I didn't. So I started in 92. We became a nonprofit in 95. And really, it's because of the financial support we have received from foundations, corporate sponsors, and many, many, many individuals over the years that have allowed us to keep going financially. What else I discovered early on was that there's a huge blind spot in the larger medical community, maybe in society at large, which still does not recognize the need for what we do, although I am so encouraged. When I look at the room today, I see this couldn't have even been possible 5 years ago. So what I understand is that it's hard to see what's not there. So what I would hear from other physicians was like, well, we're taking care of our homebound patients. And I was only seeing patients who were having difficulty getting to the doctor's office. I didn't want to be a convenience, didn't want a concierge practice. But they don't see who's not there. They don't see, and these are, the patients we serve are not the people you see in the grocery store or on the street. You may even live next door to somebody with the overgrown yard who hasn't been outside in 10 years. Those are our patients. So that blind spot was precisely because our patients are homebound and you just don't see them until they end up in the hospital. So if you work in a hospital setting, you do see them. We've seen the truth with our own eyes. Over the years, we've been gathering our own data. But the medical community has still been really slow to accept the data that's been out there for quite a while, like that big VA study. It was a 10-center study that was done over 10 years ago. And still, well, I don't know why that never got into the mainstream conversation. Ironically, it's the payers now who are beginning to see the value of what we do. And I'd like to give you 3 examples. One is Medicare. As our single largest payer, we're now in the midst of a 3-year demonstration. We're just starting the 3rd year of Independence at Home, which Tom has described how hard it is, how many hurdles there are to even enroll a patient. So in our practice with 1,400 patients, initially we could only get barely 100 patients who were eligible because of all the criteria. But they're targeting the patients who are the high utilizers, the 5% that are using almost 50% of the Medicare dollars. These are medically fragile people who are often in the last 2 years of life, who often end up with a healthcare crisis. They get to the local ER and from there into the ICU, and then they end up with all the tubes and wires attached, which is something they probably never wanted. So we attribute our success with Independence at Home to providing medical home visits plus a team of nurses and social workers who identify and monitor these high-risk patients, following them to and from the hospital and helping to bridge the gap between the hospital and the community. We believe that Independence at Home has the potential to save Medicare. Care Oregon. I'll just say one word about this, and then I'm sure Patrick will have more to say. As our 2nd largest payer, Care Oregon was quick to respond to our data on hospital admissions and 30-day readmissions. Care Oregon is now paying us a per member per month fee in addition to our fee for service to help offset the additional cost. And 3, Providence Health Plan. Recently, we've negotiated a capitated contract that includes support for these non-billable services that we're providing. I think this shows that private insurance is starting to see the value of home-centered medicine. The times are changing. Last month, I attended the annual meeting of the American Academy of Home Care Medicine. There were over 300 individuals there, physicians, nurse practitioners, PAs, social workers, practice managers, administrators from all over the country. And it was about 4 times the size of the first meeting I attended back in '98. And how we talk about home care medicine is changing to meet the times. The conversation in 2014 on managing the costliest patients, not by cutting services, but by providing additional care at the right time and in the right setting. Maintaining patients in the lowest cost settings. It's not so bad in Oregon, but as Tom mentions, I mean, nursing homes are an incredible expense to Medicare. Moving palliative care upstream and mitigating overtreatment through nuanced goals of care conversations. Ultimately, reducing hospital admissions and readmissions, which is where the big dollars are. There's a new study being published in the Journal of American Geriatric Society this month that was done by 2 pillars of the Academy leadership from Washington, D.C. It's the culmination of a 4-year project looking at whether home-based primary care actually reduced cost for fee-for-service Medicare beneficiaries. Remember, the previous study was done in the VA. 722 patients were enrolled, and they gathered over 2,000 controls who were matched for every possible variable they could think of, from age to socioeconomic status and cognitive impairment. The only intervention was management of the study group by a home-based primary care team, much like our own and Tom's. The results showed a 17% Medicare cost savings, statistically significant for those of you geeks out there, at a p-value of 0.003. Circling back to independence at home, so we are one of 18 sites, the only one west of Texas, and we've just finished 2 of the 3 years. Nationwide, there are 10,000 patients enrolled in independence at home projects, all with multiple chronic conditions and functional limitations. Our data show significant reduction in ED visits, hospital admissions, and 30-day readmissions compared to state and national benchmarks. And we don't even have the data yet from Medicare. They've been keeping their own data. The data is there to show that independence at home has the potential to save Medicare. I know I said that before, and I believed that all along, and so does Senator Wyden. In fact, it may be the only thing that will. The next step is for Congress to establish it as a standard Medicare benefit. To summarize, home-based medical care is on the leading edge of medicine. We're not throwbacks to the past, thank you very much. We are the way of the future, promising to achieve the triple aim of better care, better health, and lower cost. Most important, it's occurring in the place where most patients want to be, which is their home.